within your practice, you have a tremendous opportunity. And if you're going to build a successful sleep practice, you must be in control of patient generation. You have to do it within your network of patients and network of physicians that you have developed relationships with. And you can't depend on referrals from non-apnea physician members or physicians that are not part of your immediate network. You must put yourself in a position to screen for those patients. And in a typical dental practice, 1 out of 5 adult patients has sleep apnea. That's 20% of your patient population. And 1 out of 8 pediatric patients, which is 12%. So let's take an example of, say, a typical dental practice that has 1,000 adult patients. So 200 have sleep apnea, and of those, 160 are undiagnosed. That's a perfect opportunity to screen and refer for diagnosis. And of those 40 that have been diagnosed and perhaps were prescribed a CPAP, at 1 year mark, we know that the 85% of those 40 were prescribed a CPAP. So at 1 year mark, the 35%, 25 to 35% of compliance comes out to be about 15 of those. So the opportunity within your practice for appliance therapy is about 185 of the 1,000 adult patients that you have. And we know that dental sleep medicine is very lucrative, but I don't want you guys to think of this as a revenue generator scheme. It's not a scheme. You're providing life-saving care for your patients. This is care, when done correctly, can truly help your patients recapture the quality of life that they lost because of untreated sleep apnea. We went over in webinar number 1 how to screen your patients that suffer from sleep apnea. We went over the specific screening tools. We went over the marketing resources and how to add a patient and initiate the treatment process. And if you somehow missed it, or if you just weren't present or missed it, it's available on our YouTube page. It's also available on our website. So you can always revisit it on demand. Dentists and hygienists can screen patients through sleep questionnaires and oral exams, and that's as per the American Academy of Sleep Medicine guidelines. Okay, and the 2 questionnaires that are the most predictive are the sleep SWOT, which are patient symptoms for the patients to complete, and the stop bang questionnaire, which is for the hygienist to complete. And this is what it looks like, and the patients actually score themselves, and the score actually has a risk assessment built in. And same thing with the stop bang. It's very simple, 8 questions. Sleep SWOT was simple, 12 questions. And again, here the hygienist scores it. So when you actually combine the scores of the stop bang and the sleep SWOT, and you look at the 2 risk assessments and you combine them, you will start to notice that the correlation of these 2 to the actual diagnosis of sleep apnea is pretty high. We also went over the predictors of sleep apnea in terms of when the hygienist is doing their exam in the treatment room, looking at body mass index, which is greater than 25. So neck circumference for men greater than 17, for women greater than 16 inches, nasal obstructions. It's hard to actually look at nasal obstructions in a dental chair, but if you just look at things like crooked nose, deviated septum, narrow nasal passages, patients complaining of stuffy nose, chronic allergies, or sinus infections where they really have high nasal resistance, they can't breathe through their nose well, you know that they're compensating by breathing from their mouths. You also look for airway crowding, like large tonsils and thick uvulas. You look for, that's easy to see. You just have the patient open their mouths and take a look, and which you guys and your dental team, clinical team does it all the time. You look for dental crowding. So when you look at airway crowding and dental crowding, there's lingually tipped molars and molars, mandibular tori, constricted, narrow, high vaulted palates, that's a clear telltale sign that there's a problem with airway somewhere, because realize palate is the floor to the nasal base, and when the palate is narrow the nasal passages are narrow, and that just reduces the amount of airflow through them. And narrow mandibles, retruded mandibles, class 2 mandibular deficiencies, enlarged tongue, lateral border ridges of the tongue, the submandibular adipose tissue, and the tongue resting at or above the occlusal plane, these are all predictors of sleep apnea. So we're asked questions like snoring. Do they snore? Or have they witnessed apneic events, or has somebody ever reported they have apneic events? We also know that hypertension, patients with hypertension, 83% of patients with hypertension who are drug resistant have sleep apnea, and 35% of all hypertension patients have it. When you're dealing with BMI of greater than 25, 77% of patients with BMI of greater than 25 have sleep apnea. And once you've actually screened, the hygienist can add the patient right from within your dashboard, and the workflow continues, and the patient completes their pre-examination visits form either in your office on an iPad or put them up in front of a computer terminal. They complete it, and once they complete it, now you have to, and you can also get patients from external sources, right? So from marketing, your web presence on our site, because we actually do pretty heavy SEO on your behalf. So if somebody is looking for a sleep apnea dentist in your community, and they put those parameters in, our SEO will actually bring up your profile. And when they click it, and it will take you to our website, but to your profile. So when you want to set up your practice and your profile for success, you have to make sure that you have to actually set up your practice and your profile as accurately as possible. The accuracy of your profile and everything that goes into it, from your profile and the insurances you take, your practice locations, your preferred labs, your preferred dentists and physicians that you work with, the more accurate this information is and the more thorough and robust it is, the better it will be from a search engine optimization standpoint on your behalf, which we do. So this is a service that we provide for you gladly. We do it at no charge to you, because the more successful you are, the more patients are being helped. And once you start to fill out this entire profile, realize something: because of deep machine learning and the automation, this data is going to be pulled into subsequent forms later on. So if you don't enter something correctly, or if something is incorrect or incomplete, it will actually be reflected in the forms later on, and in the self-generating marketing letters, referral letters, and correspondence letters to patients, physicians, to insurance companies. So it's absolutely critical that you make sure that this information is absolutely accurate. Then, of course, you have to be certified to be able to use our platform. We feel very strongly about it, because this is a discipline that was not taught in dental schools or in residencies. And we don't want people practicing this discipline by ad hoc measures. The question, if a doctor is not certified, can they approve the initial screening, confirm that the patient's eligible? Absolutely. Yes, absolutely. You guys can do the screening. But to actually continue with the workflow, you will not be able to enroll a patient in and get the treatment started if you're not certified, because the certification is not just the science behind it, it's also the regulatory information, the why behind and the how behind the machine learning and the artificial intelligence and the analytics. So if you don't understand this entire process, it's really hard for you to implement it. And we don't want you to fail. We want you to succeed. And we found that the most predictable method of predicting success for our members is for them to actually take our course, get certified, and have their teams take the Sleep SWOT course, because it's a team effort. You yourself as a dentist can't do this all. You need the help of your team, and your team can't help you if they aren't trained themselves. And the team training course is included as part of your certification course at no additional charge for as many team members as you wish. Here are the top 6 barriers to implementation of dental sleep medicine. And in the first 2 webinars, we discussed the screening and the low sensitivity and high specificity in patient screening process very inconsistent incidence and severity correlation. And because they couldn't accurately screen patients, they were getting a lot of false positives and false negatives, that they were just disheartened with the whole process. Like, well, if we can't kind of screen, imagine a patient coming into your practice and you fail to diagnose periodontal disease more often than you actually do. How disheartening is it? Well, that's exactly it. And then, of course, the fragmented clinical administrative systems in webinar number 2, because this is a discipline that most of your, if not all, of your dental, management systems, your practice management systems, don't have. So we covered those 2 in the first 2 webinars, and the lack of education, like I mentioned, it's something that's not taught in dental schools or postgraduate education. This is something that you have to seek out yourself afterwards. And there isn't really an education out there, a platform out there that really gives you this comprehensive overall, view and a very thorough education on. And then, of course, the other issue that most dentists didn't like, and that's one of the big reasons why they didn't want to practice dental sleep medicine, is this complete guesswork of, how to get started in terms of when you take a bite for an oral appliance. How do you determine that bite? And all these self-proclaimed gurus talk about taking a percentage of the range of motion, and some say 50, some say 60, some say 70. I mean, how unscientific is that? A way of determining a start mandibular position. And then, of course, once the oral appliance has been inserted, then it's complete subjective trial and error titration of the appliance based on patient subjective symptoms. And we also know that if a patient feels a certain improvement in their symptoms, most dentists will stop titrating there. But we know that that's not it. From our studies and all the studies that have shown that a subjective end titration position is actually not the ideal jaw position for the maximum effectiveness that can be substantiated by a sleep study quantitatively, objectively. And of course, that relates to an inconsistent oral appliance therapy efficacy. So dentists, for these 6 reasons, don't really want to get involved with practicing dental sleep medicine. So we took that and we built the systems to address not just these 6, but also every single one of those other barriers that they listed. This webinar, the question is, when does the billing process begin? So the answer is, if we had one of these other sleep courses, and we've had, just today, I was made aware by Dr. Awazi that a colleague of ours who just joined Apnea had been to courses, and Bill, you've been to lots of courses, and so many others have been to so many courses, where they kind of give you a teaser of how to get involved with this billing process, but they don't really give you the full information. So you come back wanting to implement it, and you fail because it's not a complete solution. So the billing process begins not at the billing completion or the filling out of the insurance form. That's actually wrong. That's actually the end point. That's the last thing you do. So the billing process actually begins the moment the patient walks into your office. Filling out the insurance form, like I mentioned, is the end of the process, not the beginning. Because if we don't do everything correctly along each step of the journey, every single step, the guided step that we have, the guided workflow, having all of the proper documentation, you're not going to be able to successfully, bill and collect. So dental sleep medicine is not like traditional dentistry with some just sleep stuff thrown in. It's completely a different discipline. It runs by different set of rules, and you succeed in any discipline for the most part, but dental sleep medicine, especially by implementing exact systems and protocols, they have to be exact, because medical insurance is a completely different breed, unlike dental, where dental only requires a treatment code, procedure code. Medicine requires both a diagnosis and a treatment code. And we'll go through this in just a bit. And this is just one of the reasons why many dentists struggle. They think that their current general practice systems, their practice management systems, the EMRs can do it all. It's not true. They have to think of it, you have to think of this as a practice within a practice model. So you have your general practice, you may have your periodontal practice, you may have whatever specialty practice you have, but this dental sleep medicine is like a practice within a practice model. You mine your patient population within your practice to help them with their undiagnosed and untreated sleep apnea. So that's why apnea was conceived, to bring proven dental sleep medicine systems and workflow to any dentist anywhere in the world in a turnkey, comprehensive, end-to-end, cloud-based EMR, electronic medical records, practice management solution that's got analytics and automated workflow. So if you go to your average sleep course, you get a ton of information about the science of sleep, which is great because you have to know the why behind the how. You'll get some marketing ideas, which I can lump sum as go talk to sleep physicians and do the best to try to, get them to refer patients to you. Finally, you'll get some instruction on how to fill out an insurance form, which is the easiest part. Filling out a form is the easiest part, but then there's a whole other set of requirements around it, which we'll go through in the next few slides, that they don't talk about. And then you'll get sent home excited about your future, not knowing that you're about to crash and burn. And so many here have experienced that with a show of yes. How many here have experienced that? Exactly. Exactly. So our success is measured by your success. We are only as successful as you are. Those of you who know me, the last thing I want to do is, disappoint you guys. And I will do my absolute best. Dr. Awazi, Dr. Sharar, and our entire team will do everything in our power. We'll do everything to never, ever disappoint you and constantly bring you innovative solutions to help you build your practice and help your patients. So let's start with billing. Let's demystify billing. When it comes to billing medical insurance, there are certain regulatory requirements that are required. They're called regulatory requirements because they are required. They're not an option, they're a requirement. And one of the things is that many errors reported in claims result in audits. And if you have repeat incomplete forms that are rejected, the greater the risk of an audit occurring. And a lot of these are because of incomplete or missing required requisite documentation. And these documentations have to be maintained with you for 7 years from the date of service. Now, a lot of you perhaps, every few years change to a new system. And a lot of times people who have actually experienced changing, let's say, from Dentrix to EagleSoft or vice versa, have realized that there's a tremendous amount of loss of data. So you have to maintain this documentation for 7 years. But if you've got loss of data and you lose records, then that's an issue. So we actually, as part of our EMR, which is cloud-based, we archive data, and we archive it indefinitely, not just for 7 years, indefinitely, in a very secure portal and a secure platform. And dentists, and this is straight from the CMS position papers, this is right from CMS guidelines, dentists can bill medical insurance for appliance therapy. And proper documentation is an absolute must. In the event of a claim review, you guys, a provider, must provide sufficient information to demonstrate that the applicable criteria have been met, thus justifying payment. Else, you'll be asked to give the payment back and refund the insurance company the money. And if the information in the patient's medical record does not adequately support the medical necessity, for the oral appliance, then it's going to be rejected. So we have to create this entire narrative around, the necessity. And the documentation that's required is not just limited to medical records, but to the sleep study, the referral report, the dental lab RX. All these things actually play an important role in the documentation. And of course, the face-to-face examination record, which is the sleep screening form, it's the key, and that's required. For medicine, we have to document that initial face-to-face. Then the whole thing with telemedicine, that the face-to-face can be done actually in a virtual world. It doesn't have to be done in person, but it can be done over a computer screen. But that face-to-face documentation has to be done, and that's the sleep screening form as part of the workflow, which we'll go in just a bit. We discuss that in webinar 2, but we'll briefly discuss it as well. This is the sleep screening exam. And what you need for your sleep screening exam are pretty basic stuff. There's nothing in the entire workflow, in the entire thing, that you don't already have in your practice, or what a typical dental practice should have. A blood pressure monitor, an inch tape, which you probably don't have, but it's easy to get, to check for neck size, neck circumference, a basic dental kit with a periodontal probe, mirror, and explorer to make sure that the patient's dental health is adequate for appliance therapy. So think about the same exact way. If you were doing orthodontics on a patient, you wouldn't want to, institute orthodontic therapy on a patient with active periodontal disease or active decayed teeth or chipped, cracked, broken teeth. So the same way, you don't want to start oral appliance therapy on those patients. And, checking a pulse. And of course, then there's the proof of medical necessity. That's absolutely required. The proof of medical necessity is part of the sleep screening. As part of the sleep screening, you're going through a checklist of questions and findings that are documented in an exact specific way, and that's part of the sleep screening. And at the end of that form, you will literally create that narrative. But you also get to refer the patient for a sleep study, and you can refer to our network of physicians who do sleep studies in lab or at home, or you can select a home sleep study option for patients to one of our partner home sleep study companies, or to a physician or any lab that does home sleep study. And from there, you actually get the certificate of medical necessity, which is actually the prescription for oral appliance, a diagnosis and a prescription for oral appliance. So you have to be able to get that. And if you're working with one of our in-network physicians or sleep labs, then that process is pretty easy, because you can actually you can refer for a sleep study within the platform with the click of a button, and all the process is taken care of in the back end by the physicians or the sleep study, home sleep study company, and the report is generated. They actually upload the sleep study report and the prescription into the patient's chart right within your dashboard. So they have a dashboard similar to you, and they have access to patient information, and right in the patient's chart, they will upload the information. And as soon as they do that, you will get a notification saying the sleep study has been, the report of the sleep study has been uploaded, and you literally just log into your dashboard, go into the patient's chart, and it's there for you to review. And once you have a diagnosis, you can continue with the workflow. So typically speaking, I was just on a call with another practice, and they just wanted to get an idea as to how this works. So imagine you have a patient in your practice, you've screened, you've identified as perhaps suffering from sleep apnea, you enroll them right there, you do your sleep screening, the same visit, your hygienist in the hygiene treatment room does it, or your dental assistant in the clinical room does the sleep screening and refers the patient for the sleep study. So that's one visit. And then the patient is dismissed, and the patient comes back once you have the results. And along with the result, you get a prescription for appliance therapy, which is required. So as per CMS guidelines, you have to have proof of necessity. and that's your oral appliance prescription. And this is a medical condition, and you cannot treat a patient who has sleep apnea without a diagnosis. So realize something, just because a patient snores does not mean that they have sleep apnea, or just because you address their snoring means that you've treated their sleep apnea effectively. They're two completely different processes, and if you have gone through the implementation course or the team training, you would have seen why an obstruction is a three-dimensional collapse versus snoring, which is a one or two-dimensional restriction of the airway. So they're two very different pathophysiologic processes, and they have to be managed very differently. And just because you can eliminate one snoring doesn't mean you have treated them effectively for sleep apnea. So here's the sleep study request form. This is done electronically for the in-network providers of sleep studies, both in-lab and at home. And for those that are not part of the network, you can actually download this form and send it along. You can email, fax it to whomever you wish that's not part of the network, Apnea network. And the other issue is coding. The correct coding is absolutely required. And every few years, just like CDT codes are revised, some are updated, eliminated, added. The same thing with ICDs, which is the International Classification of Disease. We're now currently on the 10th version. CPTs are the current procedural terminologies, and the HCSPCS. So realize something, these three codes go into an effective and medical coding for oral appliance therapy, or for any therapy. And you've gotten a diagnosis back. Now is the time to do the pre-authorization for medical insurance, because there's no sense in doing a pre-authorization for medical insurance if the patient hasn't been diagnosed. I think I missed this. What if a patient already had a diagnosis of sleep apnea in the past from a physician, and they just want an appliance and don't want the CPAP anymore? That's a great question. So one thing we do bypass then, if that's the case, is referral for here. So we don't do the referral for oral appliance therapy. So as part of the workflow, if the patient or you had indicated in the past, in the previous form, the patient pre-examination form, or just in the previous questions, that the patient has been diagnosed, then this entire option of diagnosis needed will not even appear, because the system will recognize that the diagnosis is already done. You've already entered the name of the doctor and that did the diagnosis, and you would have uploaded the sleep study. So at this point, you can literally bypass this entire step of referring for a sleep study. Actually, this step will not even be available for you, since it's not required in the event you have a diagnosis. And the next step will literally be this: the pre-authorization for medical insurance. So you will complete this, you will complete this, you won't need this, because the prescription and the sleep study would be uploaded in this section right here. Completed the sleep screening exam, you would have completed the financial agreement, and the next step, you will bypass this, because this won't even be an option in the case if you have a sleep study already and a diagnosis. The next step will be phone pre-authorization. So you literally access. So the other interesting thing that you may notice is the forms that have been completed end up turning green, and the forms that need to be completed end up being highlighted in red, and they appear in the sequence they're supposed to be. So the first form that appears in red is a phone pre-authorization for medical insurance. So here we are. Okay, so all this information gets pre-populated. This data gets pre-populated. What's not pre-populated is the date of pre-authorization, which you guys can choose. Really is the day of with after calling this number, the extension, the time of the conversation, and this is the NPI number that the insurance company wants to know. So the few things that the insurance company wants to know is, number one, who are you asking about? So they would want the name of the patient, the date of birth of the patient, their policy number, and their ID number, and then of course the doctor's NPI number. And they're all here. if the patient did their job and you verified that they put in the insurance information completely, and you did your job in making sure that your profile was set up correctly and that the NPI number is in there, the correct NPI number is in there, then this will all show up without you doing anything. So here again, so these fields are all empty. So right here, the first diagnosis is the obstructive sleep apnea, and the first treatment is going to be, the main treatment is going to be the oral appliance therapy. But there are going to be other co-diagnoses, right? That you'll be wanting to manage along with the primary diagnosis of obstructive sleep apnea. So some patients might snore, and you literally pick and choose from a drop-down menu. You can choose snoring. Let's say you can choose sleep-related bruxism because they grind at night and they snore and they are tired, insomnia. They have excessive daytime sleepiness. They have headaches. They have diabetes, or they have, let's say, metabolic syndrome. They have TMD. So let's take a look. They have, opening. Let's say they have a middle closing click with pain. So you can identify all these conditions, comorbidities, and conditions that are occurring simultaneous with this obstructive sleep apnea diagnosis. And for treatment, you can actually have your oral appliance therapy as a primary therapy. You might want to take, let's say, full MAT series. You also might want to take a CT scan. You might have done a home sleep study unattended. You also might want to take diagnostic study models, but your team doesn't know the codes, and the insurance company doesn't know these words. They want codes. So when you're on the phone with, let's say, Emily, the insurance company representative, Emily will ask for the patient's name, date of birth, the insurance information, so to speak, so they know what to look for. So they know, who to pull up on their system and what to look for, and of course the doctor's NPI number. But once they've done that, you literally start asking questions as to if the patient, if this is a covered benefit, and the insurance company will say, well, we don't know what that is. Can you give us a code? And since you don't have the codes, all you have to do is your BA or your delegate, whoever's doing this on your behalf, all they have to do is literally just hover over a diagnosis and they will get the code. So this is the ICD codes in this part, and the CPTs are here. And all they have to do is just tell the insurance representative the codes one by one: the sleep-related bruxism, snoring, insomnia, hypersomnia, headaches, metabolic syndrome, all these. So you can literally keep picking as many as you wish. Hypoxemia, let's assume. So you can do that, and that's that code. And when it comes to the treatment codes, you have oral appliance code, you have the full MAT series, the maxillofacial CT, you have home attended, unattended home sleep test, the diagnostic study models. These are all here. So the first question is it a covered benefit? Yes or no. Does a patient have coverage for sleep apnea treatment? Yes or no. If it's a yes, great. And what's the percentage? They will tell you what the percentage. What's the deductible? You write that down. Has it been met? Yes or no. If it's no, it will say how much is remaining. If it's yes, then the next question won't even show up. So it's very dynamic. So as you will notice, that the entire workflow is very dynamic. So only based on your answering a particular question, if the next question is required, will it show up? If it's not required, it won't. So if it's been met, then there's no need for the next question. But if it's a no, that the deductible hasn't been met, you document how much of it's unmet. And legally, you're required, the patient is obligated, and you're required to collect this copayment because before the insurance company can pay the amount that they're required to pay, they expect you to collect this. And simple questions like if it's a covered, only if it's traumatic injury, restrictions, covered only in-network provider. If it's an in-network provider and you write down yes, and we'll go through what that is in terms of the forms that need to be filled out. So we'll go through that. Is it covered only by a specialist? If it's a yes or no, just write that down. And if they say anything else, like they need a letter of medical necessity, period, the end, then you write that down. And then you ask for a documentation of this conversation, which is, and you need to document this. You need that number because this will actually pre-populate and auto-populate in the medical claim form. This way the insurance company can actually just cross-reference this and see that you actually went through the motions of going through the pre-authorization. You literally just save and continue. And once you've done that, the next step, as you can see, so the next form that will show up is the MAD-FIT workup. And before you do any treatment, the first thing you have to do is get the consent of the patient to actually treat them. And this is mandatory. Here is the MAD-FIT workup, and I went over what's required in terms of what you need. Oh gosh, let's go through that later. But medical history, literally you go through the workup question by question in terms of just literally step by step. It literally guides you through the entire process where you actually do your oral exam, you document a whole host of different data points you go through your existing, you go through your range of motions, you go through your orthodontic and your orthognathic examination, you upload your sleeps, your baseline photographs. This actually, from the sleep screening, this actually captures it from the sleep screening. So as part of the sleep screening, when you did this, it actually migrates it here as well, so you don't have to do it. In case you missed it in sleep screening, now you have an opportunity once more to actually complete it. Maladaptive classifications, tonsils. So you document all this stuff. You do your muscle palpation, your joint evaluation, your TMD, and this will show up only if you identified the patient or the patient identified certain keywords that will trigger a TMD evaluation. So diagnostic records, it asks you to document what you've done or what you're recommending. So if you've done a CT scan, study models, full MAD series, let's say a panoramic X-ray, a home sleep study, then it will ask you to upload the panoramic and the full MAD series. So let's just say, if you didn't take a full MAD series, then you will not get the option to upload the full MAD series because you never took it. So the system will not recognize the need for one if you never identified that you took one. It doesn't have to be taken at that moment in time. It could have been taken previously in the recent past as part of the normal hygiene visit, and that's completely fine. But as long as you have it in your database, you can upload it here as well. You do your craniomandibular screening, as you can see. If it's not within normal limits, a whole host of other menus come in. But if you say within normal limits, it asks you to input certain data points from the sleep study. Some home sleep studies are type 3 versus type 4, so you don't have a lot of the information that's required that will be provided in an in-lab. So if you don't have a particular set of data, don't obsess over it, just omit it. If you don't have it in the sleep study, if the physician and the kind of sleep study didn't report this data, don't put it in. The algorithm is such that it kind of looks at the data that you're entering and gives you the predictive titration, the predictive initial start mandibular position for the most effective oral appliance therapy based on the parameters that you've defined. So you can be as thorough or as less thorough as you wish, but be as thorough as possible. So if you have the data, put it in. There's no reason why you have to omit any data that you have access to. So you do that, you document previous therapy attempts, which is important to document again. So you just literally go through step by step. If you have a patient with TMD, you can actually draw in the pain pattern. And this is pretty easy to do. So you can actually draw this way. So let's say if your patient has headaches, you can actually literally, if they have tension type headaches, you can literally drag, and it's pressure kind of a pain. So you can actually do this if it's if it's mild, moderate, or severe pain. If they experience severe pain in the back of the head and it's burning, they can do that. If it radiates, then you can literally do that. And this is all goes into creating a baseline documentation of what their, what their history was, what they presented with. And then of course, you can actually just document how much time you spent with them. Level 2, level 3. I would strongly advise you don't go level 2, raises red flags. There's no reason why you shouldn't be able to really do this entire thing in less than 30 minutes. Because a lot of this information comes from previous forms. The medical history, this part, the medical history actually auto-populates from the patient pre-examination form. So if they completed their medical history, or you checked at the sleep screening time and you completed it, then this comes here. So as you can see, a lot of this information is just a double check, because we need to make sure that everything was done. So there's really no reason, if everything was done previously to the right way, then this shouldn't take more than 30 minutes. You save and continue. And then, again, you get one more opportunity because you may have added or deleted certain things from the original phone pre-authorization. So here, you have one more opportunity to add, if you wish, let's say fibromyalgia. Then you have an opportunity to call the insurance company and say, in our clinical workup, we identified an additional issue, fibromyalgia, that we would like to consider, getting reimbursed for or covered, that can justify the need for treatment even more. And once you have done that, as you can see, you just literally save and continue. And then I'm just going to minimize that for a second. Because we took a CT scan imaging report shows up. And literally, this was developed. We developed this to help you because technically, medical legally, if you take a radiograph, you have to document a radiographic report. If you take a CT scan in your practice, a cone beam, you have to have a report. Either you can farm it out to a radiologist who will send you a report of review, or you can do it yourself. This is how we've been doing it for the past 20 years. So we model this after how I would, or a radiologist would actually go through the step-by-step evaluation process of a CT scan. And you literally just, go through it, yes or no. If it's a no, you can see how the dynamic workflow changes. So if it's a normal chondromorphology, then these other options don't even apply, as you can see. So if it's normal, then simple, adenoid hypertrophy, yes. Glenoid fossa. So you can actually just keep going step by step. Sinus superior displacement. I mean, this is an entire list. So you can just go right from here. You can actually enter the airway. So the narrowest part of the airway in an AP view, in a cross-sectional view, level 1 from the team training, actually from the certification course, that's the nasopharynx. Level 2 is the oropharynx, and level 3 is the hypopharynx. So you can actually take a measuring, you can use your measuring tools to measure, what's the narrowest is, because all these data points actually will go into the algorithm. So it's very important. If you took a CT scan, why not use that data? And why not have a report generated that will actually protect you? And also at the same time, not just protect you medical legally, but also give you the information that you really, really need for the algorithm. And it's okay if you don't have a CT scan. You don't need a CT scan. Just do the best you can. If you have a panoramic X-ray, then it will take you to a different set of menus and different set of questions to ask. But if you have it, why not use it? The more information we put into a particular algorithm, the better, the more predictive it becomes. It's pretty logical, right? So same thing again, if we have lesions of the maxilla or the mandible, as you noticed, if it's a no, then these actually get grayed out. There's no way to actually enter them. But if it's a yes, then it asks you, what is it? Is it a radiolucent lesion? Is it a radiopaque lesion? Is it mixed? So it asks you all these things. And then once you're complete, it actually goes and generates a report as documentation. And same thing here. This is for the panoramic X-ray. It has a whole other set of data points that it asks for. Again, you can continue to. But once you've done this, now this is your summary. For those of you who do Invisalign, you've got Invisalign summary. This is a sleep summary, and it literally gives you a summary, a synopsis of your clinical evaluation right from here. If you say, I forgot to add something, you can go back and complete the workup form and add whatever you omitted, intentionally or unintentionally. Or you can write from here. If you feel comfortable that you've put in all the information, you calculate your titration, your start mandibular position, and it's pretty self-explanatory. Please confirm. And this is the other important thing from practice management software standpoint, from your own practice management. You should add a D599.3 code, D5999.3 code into your practice management software as a non-billable code with the description MAD-FIT oral appliance therapy. And for accounting purposes, since we don't track how much money was collected, for accounting purposes, you should maintain that record in your individual practice management software. So from right here, you will have the opportunity to record, using an Andra gauge of where to position the mandible. It literally tells you step by step. Move the mandible forward this much, open the vertical this much, move the mandible left or right this much. And for those of you who have used the Andra gauge, you will know how to do it. If you don't know, if this is the first time you're using an Andra gauge, you can actually just literally, pick and choose the video of how to adjust the Andra gauge. And right from here, you can actually see how to do it.
Prior to placing your impression material on the board,
it's a
good idea if you just recline your patient and have them sit for about 5 minutes with the fork.
Okay, so we can actually close that out. But once you've done that, right from here, you can generate the lab script. You can also generate the primary insurance form right from here if you choose to. I would recommend that you defer this till after you've inserted the appliance, but you can also do it now as well if you choose to. But I would strongly advise you to defer till after you've inserted the appliance. Similar to a lot of procedures that you guys do, you don't bill ahead of time. Some practices bill ahead of time. Most practices don't, because they need a proof of whatever you did done. So with, let's say, root canals, you need proof of a root canal, which is a post-operative X-ray. With oral appliance, it's a proof of delivery. Okay, so right from here, you can generate the primary insurance form, or you can generate the lab script. So you can actually, let's go through this. So let's generate the primary insurance form. So realize something. As you can notice, a lot of this information auto-populates from the patient pre-examination form, where they entered their insurance information, their particular name, and everything else, the insurance IDs, their date of birth, relationship to the insured. This is all patient's responsibility. If they didn't do it, then it's your responsibility to do it. But why do something when somebody else should be doing it? It's the patient's responsibility. But you can also delegate somebody on your team to do it on behalf of the patient when the patient is there, and that's completely fine. But you can see, it's so it depends on what the patient entered. This will show up. So if the patient is employed, you have the ability to edit these fields. Place select. Well, that was the auto accident. We don't need any accidents. No. Insured's date of birth. What kind of an insurance it is. Signature is on file. The doctor referring. The referring doctor's NPI number, if you have it. Outside lab. Was an outside lab used? Yes, we're going to use an outside lab for home sleep study, and for a dental lab. And home sleep study charged us, well, our home sleep study company, our members, our affiliate company charges dentists $200. So you can report that, and a lab fee of whatever it is, let's say $250. So you can enter that outside lab. The diagnosis, ICD, and we're choosing 0, which is 10. We now this is very important. You are required to choose in the order of importance the diagnoses. So obstructive sleep apnea being the primary diagnosis will by default appear in A. The next would be, let's say, if the patient is grinding their teeth and or snoring. Does the patient have, let's say, excessive daytime sleepiness? So we can actually keep doing this. And this is all from the evaluation of the patient so far. So this menu, unlike the pre-authorization menu, is very limited, and it's limited to only the conditions that were identified as part of the screening or the medical history review or the sleep study or your clinical exam. So only those conditions will show up. Shortness of breath, restless leg syndrome. So you can keep doing that. And now comes the next form. So as you can see, this number automatically populated in the pre-authorization number. So now it's literally the first thing we do is oral appliance therapy. And the next thing is, what did we do? And this is something we do in terms of the order of things that were done, that was indicated. So when we indicated in our MAD-FIT workup, we did all these things, that will show up. So we did full MAD series, we took a CT scan, we did a home sleep study unattended, we took diagnostic study models, we did a consultation for that visit, we did panoramic imaging and oral appliance therapy. So we took an full MAD series, and it gives you a fee, a suggested fee, and it populates it for you, and you can edit it, whichever one. But realize something, when you edit this, the next time you choose full MAD series for any other patient, that's the fee that will show up, because these are your usual and customary fees. Since you're not part of the insurance network, medical insurance network, you're not obligated to use their fee schedule. So this is your UCR for whatever that is. So if you edit this to, let's say, 250, then the next time you choose full MAD series for the billing, it will show up as 250. So it remembers your previous entry. So just pay attention to that. We also did a CT scan, and we can charge whatever we want. We did panoramic imaging, and let's say it was 100. And as you can see something, when we choose whatever we do, realize something, the dates of the service automatically populate. So we don't know when you took the full MAD series, but the day that you entered it into the system, into the MAD-FIT, is the day it was recorded. So let's say you did the home sleep study. So as you can see, the date that it was done, the date that was recorded in the MAD-FIT workup is the date that will show up. And at the same time, the NPI number shows up. So all these fields automatically are done for you. All you have to do is just choose this, you see? And so let's take a look at this. We did this, as you can see. So once that's done, do you want to accept assignment of benefits? I would recommend absolutely no. So here we are. So this is the total charge for the procedure. The patient was obligated to pay $500, which you collected as the deductible. Okay. Then here, if you have multiple practices, you can actually select the kind of where you chose to see the patient. And the same thing, if it's a single practice, then this automatically populates it for you. And same thing here. Your signature is here. Your NPI number is here. That's it. It's a state license board. State license board, and save and download. And this is interesting. When you save and download, it gives you an opportunity to once again review this entire form to make sure you didn't omit anything. Okay. And if it's done, here we go. It does it. So right from here, you have the ability, it gives you the option of printing, downloading the primary insurance claim form, because all these have to be sent to the insurance company. Okay, so why not send them everything that they require instead of having them come back to you and say, well, we need this, we need that. Now, if you chose to bill at the time of the insertion, after the insertion, after you've done the insertion, then another set of options would have shown up in terms of proof of delivery. That proof of delivery would have shown up. That would have shown up. So here we can actually do primary insurance form, CPAP intolerance affidavit, and consent form. And if you notice something, all three forms got downloaded. We'll just now look at this. That's your medical claim form. That's your medical claim form. You chose narratives. It automatically populates the codes, even for the CPTs and the ICDs. And here we are. And all you have to do is just literally print, and that's how it prints in color, and send it to the insurance company. And the same thing for CPAP intolerance affidavit, if there was one. Okay. Or the consent form. And that is your dreaded insurance. So the question was, depending on the state, you need to check to see if you can send a patient for a sleep study. Some states and some insurance companies require the patient's GP refer the sleep. Yes, so you can send it to the physician, but I have not come across an instance where a dentist can't refer the patient for home sleep study. I would strongly advise all members to consider referring it to a third party, like a sleep physician or an independent home sleep study company, rather than dispensing the unit themselves. That becomes tricky. So, so it's better if you just refer to a home sleep study company. Fantastic. Okay. So the next step would be to take a bite, and we can continue this next time of how to take a bite. What things you need to register that MAD-FIT titration. But something that you already have in your practice. You know, you need your basic dental set, you need an Andra gauge, you need your bite registration materials, your assortment of trays, or if you scan, you need a scanner. You know, and you can actually get the Andra gauge from Ohlendorf Labs, or you can, you know, ask one of your, you know, dental labs if they have it. But if they don't, Ohlendorf carries them, and they have them, and they're pretty reasonable. We'll continue this next time about the insertion visit, what to document and what you need, and the follow-ups will be next time. So as you can see, the barriers, the top 6 barriers, we've actually addressed every single one of them. We've taken care of the education, we've taken care of the sleep screening, we've taken care of the how to take a bite and where to start the bite at, and where to record the optimal bite position that will translate into oral appliance therapy efficacy. And of course, the clinical and administrative systems are pretty, you know, seamless. And the medical insurance billing, the dreaded medical insurance billing, is taking care of it for you. You know, so how's everyone doing? Let's. So yeah, the next webinar will be on the MAD-FIT workup and using the Andra gauge to record the bite position. And that's going to be on June 4th, Tuesday. Yeah, that was the objective, is to really make it very simple for everyone to, you know, to use. Literally, there isn't anything here that you guys saw that requires tremendous amounts of, you know, effort into implementing. This is the general info for the tech team. You guys can reach us there. You can also, well, we're building our AI, and Cato is fantastic. For those who haven't used Cato, do try Cato. It's our AI, and it's that little icon on the bottom right of your screen that shows up. You can ask it any questions, and if it doesn't know the answer, it will find the answer and get back to you within 24 hours. So yeah, my email is pretty straightforward. It's Dr. Pankaj Singh at apnea.com. So we've been working really hard, and we continue every single day to constantly make it better and better, because we don't believe there is a perfect system out there. So our job is to come as close to it as possible. Question is from Doug. Does Apnea provide sleep physicians and HST and video conferencing? Okay, so we don't provide any HST, right? So it's all through our partner physicians and home sleep study companies. And if the sleep physician does video conferencing for diagnosis, then by all means they do. That's fine. That's something that they do independent of us. All we do is we facilitate that that network and that referral. I'm the billing person at my office, and I will say, if you have all the information at the beginning, you can successfully bill for OAT Appliance. So when you have everything at the beginning, in terms of if you have a diagnosis, if you don't have a diagnosis, that's a different story. But if you have a diagnosis and you have done your clinical evaluation, because there are certain things that you will not know just by patient's medical history or just by diagnosis of sleep apnea, all the other things that may be required to bill in terms of building a narrative for the justification for treatment of this condition. Because people who brux at night, 3 out of 4 patients who grind at night, who brux at night, have sleep apnea. So if we don't provide the narrative and create this case, so to speak, we're building a case, right? Imagine if you're going before a judge and you want to present a case for a successful verdict in your favor. The more evidence you present, the better it is, the easier it is for the jury to make a decision. And constantly, we don't accept mediocrity. We don't accept status quo. Even though this is light years ahead of anything else, I believe that it can be even better. And with your help, it can be. Well, if there aren't any more questions, I thank everyone for their attendance. I know it's late at night. Thank you so much for all your support. And I can thank you from the bottom of our heart, from Dr. Awazi, Dr. Sharar, myself, and the entire team here at Apnea. We wish you tremendous success with implementing dental sleep medicine into your practice. And if there are any questions, or if you have concerns, or anything, do give us a call or reach out to us via email. Okay? Have a great night, everyone. Thank you.